and it's a great pleasure for me to introduce Dr. Amna Qasim. I've known her for some years. She is working at the University of Arkansas for medical sciences, and she is a graduate of, and she was the best student she graduated in 2015, right? And
Yeah.
then was at, she did her pediatric residency from the
UTM. Yeah.
University of Florida in Galveston, right? And then she did her fellowship in cardiology
Yes.
from, if I remember correctly, let me open up the CV.
It's Texas Children's Baylor's.
Yes. And finally, she is working now as assistant professor at the University of Arkansas, right?
Yeah.
But more importantly, she is an amazing, prolific writer and researcher, and she has more than 30 publications, a lot of research papers, and she has done a lot of lecture series, and she's very actively involved in teaching and teaching residents. And I was looking up some of her publications, very interesting, like congenital heart disease and genetic biomarkers. What are the most difficult areas in single hypoplastic left heart, right? Like very scary areas, correct? Yes. So very interesting. And she asks some very thought-provoking questions in her publications, which are very nice. So, and in addition to that, she is a wife and a mother of a very cute girl, and she's the youngest of four siblings. She was born and raised in Karachi, and she loves sports and is very active. And in summary, we are all extremely proud of her. So I'd like you to start, Amna.
Okay, Dr. Khan, thank you so much. So like Dr. Kamal mentioned, my expertise is in pediatric cardiology. I do imaging, so fetal echo, transthoracic echo, TEEs, and that's where my interest is. But
Yes.
I tried to design this talk for all general pediatric base, also just workup of chest pain. We get a lot of referrals for chest pain. That's the bread and butter of cardiology. Most pediatricians, if they hear chest pain, they put a referral for cardiology. Most ER doctors, they see chest pain, they call the cardiologist. So this talk is designed for how do we think about chest pain and make it less scary, because every time people hear of chest pain, they get scared. I don't have any disclosures, and so we'll review common etiologies, what are the red flags, and how do we work chest pain up. So chest pain accounts for, this is data for United States. We don't have data for Pakistan, but data for United States says all the pediatric ED visits, chest pain accounts for 0.3 to 0.6% of ED visits. It's rarely cardiac in nature. Does anybody want to guess? Tuba, do you want to guess how common is chest pain due to the heart? The patients who present to the emergency room for chest pain, how commonly is it because of the heart? What percentage is because of the heart?
I mean, rarely, I don't know the percentage, but most of the time it's the respiratory that leads to cardiac generally.
So it's 1%, and there's somebody actually looked at it. The authors, Salib and colleagues, they reviewed 3,700 patients who presented with chest pain, and the actual cardiac pathology was only found in 1%. That's the number I tell families, like 99% of the time, it is not the heart. But every time, 99% of the time, the first thing parents think of and usually we think of is the heart. So I just wanted to review some common etiologies. So when you think of chest pain, it's most commonly musculoskeletal. The second most common thing can be pulmonary. And GI, it can be psychogenic, it can be miscellaneous causes, and then cardiac would be one of the last things. So when we say it's probably musculoskeletal, what musculoskeletal things can cause chest pain? The most common one is costochondritis, which is inflammation of the ribs and the costal margin. So usually there is a history of a viral illness. They've had some cough, congestion, fever, And then when you palpate, it'll be tender to touch. It can be muscle strain. So either they were lifting something heavy or they went to the gym and strained a muscle. So that can be usually will be unilateral trauma. So we're playing some sports and got hit by a ball or a bat or something. Then there's something called precordial catch syndrome. This is just random sharp pain, can happen while you're sitting, and it can usually is unilateral and it worsens with inspiration. So it can kind of mimic pleuritis. And then other chest wall abnormalities, so pectus or either excavatum or carinatum can cause chest pain. Slipped rib is when the ribs are more mobile, and you can palpate this by doing a hooking maneuver where you put your 4 fingers underneath the costal margin, and if you palpate, you can make the ribs move, but that also elicits pain, and patients don't like it. Or it can just be idiopathic, sharp, unilateral pain. So pulmonary causes, most common one you think of is pneumonia. So usually we'll have other symptoms. Usually we'll have a fever, cough, you'll hear crackles when you listen to them. Pleuritis is pain, again, that gets worsened with breathing, can be unilateral or bilateral. Pneumothorax, so sudden onset, shortness of breath, increased work of breathing, can have a history of trauma or can be spontaneous. I still remember the first time I saw spontaneous pneumothorax. I was a third-year medical student at Aga Khan. It was, I think, a 12 or 13-year-old girl, no previous diagnosis, came in with a pneumothorax, but she looked like she had some connective tissue disorder. She was tall and tall arm span. So she got diagnosed with pneumothorax. So that started all the workup. Then she got an echocardiogram. She had a huge aortic aneurysm. So then she needed aortic root replacement. And that's how I got interested in congenital heart stuff. It was as a third-year medical student, that one case that, I won't forget in the ER. So her first gateway into the hospital was chest pain, pneumothorax. Asthma can present with chest pain very commonly. So those patients will usually be holding their chest, will be wheezing. It worsens with exercise. And sometimes bronchodilators help with those symptoms. Chronic cough, if somebody's been coughing for a long time, that causes muscle strain, that can cause chest pain. Pulmonary embolus, we've been seeing more cases, can happen in girls who may be on estrogen-containing pills. So it will present with shortness of breath, cyanosis, so they will have desaturations usually if there's a large pulmonary embolus, and this can be an acute emergency. Pulmonary contusion, again, can happen after a trauma or road traffic accident. Pleural effusions can be infectious, in which in Pakistan you commonly think of infections like TB, or in the US it's mostly prior to post-surgery. In a cardiac patient, if we see effusion, we usually think of surgery. Or aspirated foreign bodies in kids, especially toddlers, like my kids' age. They put everything in their mouth, and some things can actually be pretty dangerous, like button batteries. If they aspirate it can, erode and cause fistulas and can become medical emergencies. So this is an example of X-ray of a kid who had aspirated a little tiny piece of a Lego, came in with chest pain. Or kids, if it's a 3-4-year-old, they may not even say it's chest pain. They may just be holding their chest or not breathing right. So GI causes of chest pain, the most common one we know is reflux. So acid reflux causes burning pain. Usually the history will be that pain worsens with eating, improves with certain diet. Peptic ulcer disease will not be a classic mid-sternal chest pain. It will usually be epigastric or lower sternal pain. And in this, you can elicit pain with palpation. And esophageal spasm can be random pain, usually with certain foods like solids that are harder solids will just cause a sharp, sudden pain after eating. And then cholecystitis, we know, can cause right upper quadrant pain, but sometimes people will complain of right lower chest pain also. Miscellaneous things to think about, like just in teenagers going through puberty, breast development can cause chest pain. Hematologic things like sickle cell in the US, thalassemia, or other blood things in Pakistan. Herpes zoster, so you can present with sharp pain. It's rare in kids, but can happen. Usually pain will start before the rash comes on. And then toxin ingestion. So did they accidentally, and this again, toddlers will do this, like drink some green cleaning liquid thinking it's juice, and then that can cause esophagitis. So history is important. And then again, in our population, we always think of drug use, which I think something everybody should think of. Amphetamines, cocaine, marijuana, all linked with acute MI. Even marijuana, which has been, people think it's a benign drug, it's not. Psychogenic things. So a lot of times, a lot of our patients will complain of non-specific chest pain, and you take a good history and you just don't find any clear association. And the pain is worse when they're at school, or, when they're with dad, and, certain triggers make the pain worse. And those things, point towards more a psychogenic element of chest pain. But that's usually a diagnosis of exclusion. So we have to make sure you rule everything else out before making that diagnosis. So I wanted to talk about cardiac next, which is why we're all here. Cardiac, when you think of cardiac chest pain, it can be because of an anatomic problem, so structural problem, or a myopericardial issue, or an arrhythmogenic problem. So anatomic problems that can cause chest pain in pediatrics. So we're pediatrics, so we don't think about coronary artery disease. We think about structural congenital abnormalities or acquired abnormalities. So left ventricular outflow tract obstruction is the most common one, which can be aortic valvular stenosis or hypertrophic cardiomyopathy. Anomalous coronary arteries. So coronary arteries are originating somewhere that they should not be, and the thought is that during exercise or exertion they can get squished, and there is an impedance in coronary blood flow. There can be aneurysms in coronaries. And what population do we see that in? Coronary aneurysms. Anybody? In kids, who gets coronary aneurysms?
Kawasaki.
Right, Kawasaki patients. So, and a lot of times Kawasaki patients, even in the Western world, are not diagnosed, and they come in 2 years later when they've already developed aneurysms. That's rare in the Western world, but in Pakistan, it's pretty common. And then aortic dissections, again, very rare, but we've seen a few. And these will be more commonly in patients who have a connective tissue disease like Marfan's. Those are the most common structural problems. And then myopericardial problems. So either there's a problem with the cardiac muscle, so cardiomyopathy, or inflammation of the cardiac muscle, myocarditis. Most common etiology is viral, or pericarditis, same thing. Inflammation of the pericardial sac, most common etiology is viral, or effusion, which usually is a sequel of pericarditis, or arrhythmogenic. So there is an abnormal rhythm that kids will say, "Oh, my heart hurts." And a lot of times kids will say, "My heart hurts," and we do an EKG and they're in SVT, or we do put on a Holter. And it's during those episodes of SVT that they're saying their heart hurts, because kids don't always, describe their feelings appropriately. They don't say it's beating fast. They can just say it hurts. The most common arrhythmia in kids is supraventricular tachycardia, which thankfully is not lethal. But can, if they're in it for too long, can cause dysfunction. VT is rare, but can happen. And then these are rare, and especially inheritable arrhythmia disorder is rare, but can lead to sudden death. We will not go into a lot of detail of arrhythmias today. So I just wanted to talk about some of the more common things, some of the more common cardiac etiologies of chest pain. They are overall not common, but if they're present, they can be life-threatening. So what is hypertrophic cardiomyopathy? This is a clip of an echo. And so this is the left atrium, this is the left ventricle, this is the aortic outflow tract. And this here is the interventricular septum, and it's very thick. It's supposed to be 20% of what this is. So this is severely hypertrophied interventricular septum. And sorry, let me go back and play it again. So that's diastole, and then in systole, when the valve closes, when the blood is trying to leave the heart, this thick muscle obstructs the flow of blood out of the heart. And that is what causes these patients to have certain symptoms, like chest pain. These patients are also at very high risk of sudden death, and the sudden death is not related to the thickness of the heart muscle. The sudden death is related to the scarring in the heart muscle. So usually they have a myopathy. That means there is some injury happening in the heart muscle, and because of that injury, there is scar tissue forming in that heart muscle. And because of that scar tissue, those regions can cause ventricular arrhythmias, VT or VFib, and those arrhythmias are what cause sudden death. So we'll just talk about that a little bit more in detail. So this is a genetic heart disease, so usually autosomal dominant. So you'll hear of dad has it, and dad's dad had it, and then now dad's son has it. So whenever we hear of, oh, multiple family members died in their 30s or 40s, you should think about heritable cardiac diseases like hypertrophic cardiomyopathy. The prevalence is 1 in 500, but not everyone has a severe disease. Like we talked about, the pathophysiology is left ventricular outflow obstruction, diastolic dysfunction. So the heart contracts fine, but it doesn't relax normally. And they can have ischemia because coronaries come from the epicardium and have to fill inside. So when the thickness is so thick, the coronaries can't supply all the way into the endocardium, and there can be ischemia, and then they have arrhythmias. So sudden cardiac death, this is just a board question they like to ask, is not associated with degree of outflow obstruction. It's really associated with how much scarring they have. ECG is pretty sensitive in these patients. So they come in with chest pain, you do an ECG, 75 to 95% of the time, you should be able to pick up there's something wrong. Is this the most common cause of sudden cardiac death in athletes? It used to be, it's said to be the most common cause, but we'll come back to that question. Here are some examples of some patients that I took care of with the hypertrophic cardiomyopathy. So to this left, this is just an angiogram. There's a catheter retrograde in the aorta, and we inject contrast, and you can see the left ventricle fill. But notice here, it's supposed to fill all the way around here, but it's not, because this is all white stuff is all the heart muscle. And so the apex is all narrow. The cavity doesn't fill because of how thick the muscle is. This is diastole, and in systole, notice how small it gets. It's almost gone. The cavity size is all gone because of how thick the muscle is. Same thing is an MRI of the, so a lot of times we will get MRIs on these patients. MRI can help with noticing how much scar tissue is in the muscle. And so the white arrows are pointing toward that scar tissue. And this is an angiogram in a different patient. So these patients can also have coronary abnormalities because of how thick the thickening happens. And this is a catheter in the left coronary artery. So this is the left anterior descending coronary artery, and the circumflex wraps around. And notice how the left anterior descending gets really narrow, especially during systole. So this was filling diastole, and systole, you notice that the filling, there's a deficit in filling, and that's because there's a muscle band that's compressing on the coronary. So sort of like a heart attack for a kid. We call this a myocardial bridge. So the treatment for this is not a stent in the cath lab. It's actually the surgeon goes in and cuts that muscle out. Okay, ECG example. Does anybody want to point out? You may have seen it when I showed this slide accidentally. What's wrong with this EKG?
So the inverted T waves?
In which leads? So T wave inversion in kids can be normal in V1, V2, all the way up to V4. But if you notice T wave inversions in V5, V6, or inferior leads, 2, 3, AVF, that's almost always abnormal. So especially V5, V6, T wave inversion is abnormal. So first abnormal thing is that the voltages in the lateral leads are really high. They're so high, they're all overlapping. So anything greater than 5 to 6 boxes is high. And then there's T-wave inversions. So that's pretty characteristic of a hyper. So if you see an ECG like this, we should request an echocardiogram. People have done a lot of studies on who in hypertrophic cardiomyopathy has a risk of dying, and the reason people care about this is who should we monitor, how frequently do we monitor them, who should we allow to play sports, and who needs a pacemaker defibrillator device. That's the big question, because it was thought, why don't we give everybody a defibrillator? But there is a lot of morbidity with defibrillators because it can shock them. They could be walking around and a certain stimulus could shock the patient, and that can be very traumatic. So now we're shying away from putting defibrillators in everyone and truly doing a risk assessment and who needs it. And so these are some of the risk factors that put in here. We don't need to go into details of this, but if somebody has a family member who died suddenly, if their hypertrophy is really severe, if they've had an episode of ventricular arrhythmia, or their MRI looks really abnormal, all of those would be risk factors for closer monitoring or defibrillator replacement. So medical therapy, first line is medications that slow the heart rate. So beta blockers slow the heart rate. The reason for that is the slower the heart rate, the improved diastolic filling, and calcium channel blockers. So the most common calcium channel blocker we will use is diltiazem. Surgical therapy is once you tried medical therapy and the patients are still symptomatic. The surgical therapy of choice in kids here is septal myectomy. So the surgeon goes in through the aortic valve. Obviously, the patient's on bypass, they arrest, and then they cut out this muscle. In older patients, they do what's called alcohol septal ablation, where the surgeons inject alcohol. But in pediatrics, the surgery of choice is myectomy. And then typically, if they're going to do that, they will also put a defibrillator. And for sports, again, 10 years ago, we used to say no sports for anyone, but guidelines are changing. And so now it's something called shared decision making. You tell them what the risks are, but you still allow them to play sports, but make sure they know if they're playing sports, they should be an AED close by and they should know the risks and all those things. There are a lot of guidelines. Again, I don't think we need to go into details of that. Some other conditions that may elicit chest pain with
So
exertion.
I have a question about the hypertrophic cardiomyopathy. So as you mentioned that the sudden death is not due to the muscle, it's due to the scar, right? So then in theory, would the myomectomy still be good, or is it, have we seen the natural history whether it even affects or it does not affect?
Helps with chest pain symptoms. So usually they have chest pain symptoms because they have outflow tract obstruction. So the myomectomy helps with those symptoms because it relieves the outflow tract obstruction, but it does not take away the risk of sudden death.
Thank you.
Typically, if there's a risk of sudden death or clinical assessment of sudden death that they're high risk, they will put a defibrillator. So mostly whoever is undergoing myomectomy will get a defibrillator also along with that because we know we've now added additional scar to the muscle.
Thank you.
Yeah, this is a very challenging population. So other conditions that may just wanted to see if anybody had ever seen stuff like this, but these are some conditions that are not congenital heart disease, but they can present with chest pain and the echo will be abnormal. One is pulmonary hypertension, common in our world where we have a lot of preemie babies now, and or pulmonary embolism, which can present at a young age too. Usually is a thing that you see in older patients, but we've seen some in teenagers as well. Both of these will present with right ventricular dilation and dysfunction. And so we always have to wonder whether it happened. If it's a, history helps a lot. So if it's a preterm baby, you think more about chronic pulmonary hypertension. But if it's a teenager who was fine last week and now suddenly has this chest pain and the right ventricle dysfunction and cyanosis, when you think about pulmonary embolism. Okay, going back to sudden cardiac death in the athlete, this is a hot topic. It's very rare for this to happen, but if it does happen, it gets a lot of media attention and parents get really worried. And so does anybody want to guess what the leading cause of sudden death in athletes is?
Arrhythmia?
That's good. It's a good choice. So that's a good answer. So if somebody was to do an autopsy on an athlete, and this has been done, if they did an autopsy on athletes that died, the most common thing they find is a structurally normal heart. So we think that the most common cause is some sort of arrhythmia, and the structural anatomy is normal. And then second is coronary artery anomaly, and third is hypertrophic cardiomyopathy. So there was one study many years ago that found that in their cohort, hypertrophic cardiomyopathy was the highest. And that's what all the board questions would say, but people have done a lot more studies and this is more realistic. This is what I've seen in clinical practice, and this is more realistic and accepted now that the most common problem is not a structural problem, it's most likely arrhythmia. So what's coronary artery anomaly? So we know we all have two coronary arteries, and I'll use the CT scan to show what they are. So this is anterior, this is posterior, right, left. So normal right coronary artery arises anteriorly and normal left coronary artery arises here. And so if the coronary arteries arise abnormally, that's called the anomalous aortic origin of coronary arteries. So in this picture, the right coronary artery is arising from the left and coursing like this in the groove. And when that happens, the thought is during activity, this coronary circulation can get impeded by the dilated PA. There are lots of different theories. And so that may increase risk of sudden death by causing coronary malperfusion. So again, coronary flow is going like this and it can get compressed. So anomalous, it can be anomalous right aortic artery or anomalous left aortic artery. The right is 4 to 5 times more common, but the left is just more often associated with sudden death. And management of this is so controversial. in our world. We're still debating the best way to risk stratify these patients, because cardiac surgery is also not low risk. So this was something that, you know, got a lot of press attention because it was a 17-year-old football player who suddenly died, and he ended up having an anomalous coronary artery. He did not have any chest pain. He used to be a football player. He used to play every day, but that one day he had just suddenly dropped. So exertional chest pain is not a universal indicator. You know, a lot of patients don't have any symptoms, but if it does occur, it can be early or at peak exercise, or right after exercise. So whenever you hear of exertional chest pains, if somebody has chest pain while they're working out, for adults, you know, if they say chest pain while they're climbing up the stairs, you should always get worried. And in kids, if they're playing sports and they have chest pain, you should get worried. So the centers that are doing the most research in the US are Texas Children's Hospital and Boston Children's Hospital, and they've both published their how to do risk stratification of these patients. And a lot of other centers are just adopting what they're doing, but they do a lot of testing to see who needs surgery and who's at risk. And this is just an example of their guideline. Even us at Arkansas don't follow all of this because they do a lot of testing. They take every kid to the cath lab and do FFR, IFR studies, which is kind of high risk too. So the one thing I wanted to point out in this algorithm is that it's history that will really help a lot. So if their chest pain is exertional, if they had any VT or high grade PVCs, or if there's troponin, they had chest pain, you check troponins and they're really high. All of those things should, you know, alert you that something's not right. Same thing with the anomalous reft. Sorry, anomalous, right? And then pericarditis. It's inflammation of the pericardium. You know, pericardial sac has 3 layers. The most common etiology is viral. Second most common can be bacterial, fungal, parasitic, or non-infectious etiologies can be autoimmune. The most common one is we see is lupus, and the second most common we see is after a heart surgery. It can be drug-induced, can be neoplastic, or some other metabolic thing. Generally, pericarditis patients will present with chest pain. And this chest pain will get worse when they lie down. And when they sit up, it gets better. And coughing or inspiration makes it worse. So similar to pleuritis, if the chest pain gets worse with inspiration, think of inflammation. They may have abdominal pain because of distension of the hepatics, because of the pericardial fluid that it just pushes on the liver. And they may have a fiction Rab1 exam. So there was a single center study looking at what are the most common symptoms in patients who are confirmed to have pericarditis. The most common symptom was chest pain. So 96% of them had chest pain. Half of them had fever, and about a quarter had vomiting. So a lot of cardiac symptoms can also have GI coexisting symptoms like abdominal pain, vomiting. To make the diagnosis of acute pericarditis, you need 2 out of the 4. So chest pain plus any one of these. So it can be a pericardial rub or ECG changes or an effusion. And the ECG changes most characteristic are diffuse ST elevations, as you notice, there's ST elevations in all the leads. Diffuse ST elevations, no reciprocal PR depressions. Or ST depression, sorry. So what workup is recommended? This is from the European Heart Journal on what testing do you do if you suspect it. So ECG, echo, chest x-ray, and inflammatory markers. So ECG, echo, do a chest x-ray, and check inflammatory markers like a CRP, ESR, or troponin. So pericarditis can be challenging because it can be acute, like, you know, the symptoms just started, or it can be going on for a long time. So if it's been going on for greater than 4 to 6 weeks, we call it incessant, like it's just difficult to control. If it's been greater than 3 months, then it's chronic. If it's new onset, we say acute, they get better, they don't have any symptoms for 4 to 6 weeks, and then things come back. That's recurrent. That's very common after cardiac surgery. We'll see they get an effusion, things get better, and then it comes back. So about a third, so 35% of pediatric patients can have recurrent pericarditis. NSAIDs always as a cornerstone of management for both acute and recurrent. And steroids, you know, people love using steroids, especially in Pakistan. I remember like steroids were thrown out all the time, but it has been shown to be associated with recurrence, and we know have a lot of side effects too. And colchicine has been shown to reduce rate of recurrence. Here are some acute, and we don't have to, go through all the details, but I just wanted to point out for pericarditis, really, if treating them, you have to treat them with a good dose of NSAID and for a decent duration. You don't just say take ibuprofen as needed. You give them a good dose of ibuprofen. So for a kid, about 10 milligrams per kilo every 8 hours for 1 to 2 weeks. For fully grown teenagers, 600 milligrams. And then a lot of studies recommend tapering the dose. And then colchicine is usually at least for 3 months, sometimes even longer. So if it's chronic pericarditis, you may even treat for 6 months, at least 6 months, sometimes even longer. I took adult data. Obviously, adults use aspirin also. We don't use aspirin because of the risk of Reye's syndrome. So workup of chest pain, we've talked about a lot of it, but the most important thing is actually history. So you ask the patient, what were you doing when the pain started? How long did it last for? Where does it hurt? What makes it better? All the same things. And, we always ask in history, did you pass out? Trouble breathing? And then don't forget family history. Because a lot of times people forget to ask, oh, dad died when he was 40, and families forget to mention it too. But that can really be for things like hypertrophic cardiomyopathy. The only thing it would be a family history sometimes. And then red flags, like when should you get worried for that this may be the heart, is if it's with exercise, or if there are any palpitations. If anybody says they have chest pain and they passed out, there's a family history of sudden death or cardiomyopathy. As there's a known history, we knew this patient had aortic valve stenosis, okay, then you should get worried. There was a known history of Kawasaki disease, known history of connective tissue disease, or there are ECG abnormalities. One of my coworkers always says, I would like to order a physical exam, because here I miss being in Pakistan, because we used to stress a lot on physical exam, but in the United States sometimes I feel like there's just so many tests that before we even see the patients, they get 10 tests. They get an echo, they get an ECG before anybody even examine them. And you can obviously make a lot of you can really make a good diagnosis with a good exam. So examine for deformities, look at workup breathing, palpate for tenderness, and then listen for heart sounds. ECG is recommended for workup of chest pain. ECG abnormalities are infrequent, so it's not a sensitive test. You won't pick up all of the problems with an ECG, but if there is a problem on ECG, it's specific. It can help identify conditions like we talked about, hypertrophic cardiomyopathy, and then for arrhythmia disorders, if there's your pre-delta wave pattern or pre-excitation pattern, we can see that there's familial arrhythmias like long QT or Brugada, certain rare things. Those things you can see on ECG. Does anybody want to take a shot on what's wrong with A and what's wrong with B? Well,
it looks like ST elevation, diffuse, so can be pericarditis. B looks like T-wave inversions.
Good. So A is actually nice job identifying. It's actually normal. So you can have T-wave inversion, V1, and then you can have these ST segment. Like it's the ST segments are when we look at elevation, you look at PR segment, and it has to be a horizontal upsweep. So when it's upsloping upward, this can just be early repolarization. And the ST segments are just still changing. They're supposed to invert. They're still supposed to be inverted in peds, and then they go to their normal upright in B5, B6. So this is actually an ECG of a normal athlete. This can be seen commonly in African Americans too, these upsloping ST segments. And these are all abnormal. So there's T-wave inversions all the way down to V5, V6. Whenever V5, V6 T-waves are inverted, that's abnormal. So this patient had hypertrophic cardiomyopathy. Who should get an echo? It seems like everybody gets an echo, but really there are guidelines for appropriate use, and when you're resource intense poor settings, you should be very careful on who gets an echo because it's expensive. So again, things are if it's chest pain with early in exercise or at peak exercise, or if they were exercising and they suddenly dropped, had syncope episode. Those are all very concerning and should get an echo. And all the other things are maybe. And so there's a paper from 2014, and that has an appropriate use criteria. So exertional chest pain is a category A indication, abnormal ECG, and family history of first degree relatives with sudden death or cardiomyopathy. Everything else is couldn't be used, and the reds are should not be used, not appropriate use. So non-exertional chest pain should not get an echo. Normal history, benign history, no other concerning symptoms should not get an echo. Sorry, my sliders. So I just, in summary, chest pain is rarely cardiac, and history can be very important in helping with the diagnosis, and just knowing when to refer to cardiology, and understanding that most chest pain can be managed by the pediatrician. This is just a picture I like from the first cardiac surgery done for a blue baby. That's all I have. Does anybody have any questions? Who's in Pakistan, Abhi? Tuba, I know you're at Alabama. Is somebody at Aga Khan right now, or other places in Karachi?
Yeah, I see my colleague, Professor Masood Sadiq, has joined us. He is the dean and he's the professor of pediatric cardiology in Lahore.
Oh, sorry, I didn't see.
Yeah.
Okay.
So,
Thank you
Zainab,
for
yes,
may I say something?
yes, yes.
Thank you very much. I think that was very comprehensive talk for a pediatrician. Obviously, chest pain is something which we see very often. And I think all the relevant potential causes and their management plan has been very well described. A couple of things which we see in our setup a lot. I'm sure you see that as well. And one of them is very common psychological or psychogenic pain, which particularly occurs in adolescents, and they don't come with a definitive history. It's just a current screen time and many other social related things with which they come in and have a chest pain. And obviously, you need to be careful in terms of declaring them as psychogenic, and you have to, even as a cardiologist, make sure that they don't have a primary etiology. Otherwise, I think she has covered everything that I could think of.
Yeah, I wonder if, and we know that anxiety and all those things are going up with the social media generation, and
Absolutely.
it's a problem. It's hard, so hard, and I feel like we see, I don't know how much parental anxiety you see, but I feel like the parents also come in very anxious because the people are reading things online and googling all the things and getting worried, and half the time we have to do studies that are not indicated, but just to reassure parents and kids. So it does make it very difficult, but like I agree with you, psychogenic is supposed to be a diagnosis of exclusion, so we still have to do like a thousands of dollar workup to make sure it's not. How I wanted to know, how much does it cost to do a full echo at a
Oh, it's not costly in Pakistan. I know Karachi is slightly expensive than Lahore, but in Lahore it's about 5 to 6,000 rupees. So that's not a lot. It's a lot from Pakistani standard, but otherwise 5 to 6,000 is
for the
the
patient to
usual.
they have to pay out of pocket?
If they come to your clinic, yes, they have to pay out of pocket. But if they come to a hospital like Children's Hospital, everything is free.
Have you heard of anomalous coronary surgery in Pakistan? I should ask.
I've not heard it. It's being done routinely. I think there are certain things which are not known to people. We have two outstanding cardiac surgeons. Dr. Asim Khan was at Cleveland Clinic, and he's with us for the last 15 years. And anomalous coronary artery surgery is being done in Pakistan for the last at least 10 years. I have a big data on anomalous coronary artery diagnosis and surgery.
Awesome. That's great.
Yeah, anomalous coronary is obviously any infant or any under 1 year, if he comes in with excessive crying, sweating, heart failure, or anything like that. Of course, we always consider that. And we make a diagnosis for anomalous coronary, I would say, at least once a month.
Really?
It's not, yeah. We cater for a huge population. Children's Hospital is the largest referral center for the country, where we do close to 1,300 surgeries a year and close to 1,000 interventions a year. And that I'm talking only of Children's Hospital, not the private setup. Asim does another 700 to 800 surgeries at Ittefaq Hospital, which is a private setup.
Wow.
So
1,300 plus 7 to 8. That's crazy.
yes, about 2,000. Yeah. And this is between three surgeons, but primarily done by Asim.
Pakistan is amazing. We, in the US, There's so many centers that each center is only doing like 250, 300 a year.
Yeah. I can understand that. Yeah.
Only the biggest, I think the biggest center, which is Texas Children's, did 1100 last year, but 2000 is crazy. By one,
Yeah. Well, Texas Children is close to 800 beds. Children's Hospital Lahore is 1350 bedded. We have 110 bedded cardiology unit and cardiac surgery unit. In addition to that, have 15 bedded cardiac surgery ICU, another 6 bedded cardiac ICU, and a 10 bedded angiography suite with 3 cath labs, one of them being biplane. It's a huge setup, actually.
amazing. I have never been, but inshallah, I'll come visit sometime.
Yeah, please do. Please do. We are holding Asia Pacific meeting, which Khaled has mentioned in the group as well, and I have mentioned as well. This will be April next year. So please do come if it's possible for you.
Thank you so much. That's great.
Thank you.
So I have a question for you. If as Dr. Amna Qasim mentioned that they do come across a lot of sudden death in sports. So what is your experience with that? What are the underlying causes in Pakistan?
Well, it's there, but it's not something which comes across very commonly. I must admit that, because if somebody dies, they don't necessarily, the family would be screened or advised to be screened. So yes, I have a couple of families in my follow-up where there was a family history of sudden death during sports, and then the rest of the family members were screened. One of them turned out to have Brugada syndrome, which I'm sure each one of you knows is a rare condition. But the other one, everybody was normal. I have few families where there's a history of not sudden death, but near death. And a couple of them had hypertrophic cardiomyopathy. But otherwise, I don't think it's a very common thing here, because if somebody does die, the family wouldn't know and they wouldn't come to medical attention thinking that why did it happen in the first place?
Thank you.
Because postmortem is not compulsory. So people would just unfortunately, the rest of the family would, although at risk, but wouldn't know that they are at risk.
Yeah.
All these, genetic issues must be more common in Pakistan than elsewhere.
Well, absolutely. We were lucky in the sense that we developed a collaboration with a German partner through Professor Humar Chima, our pediatric gastroenterologist, hepatologist, and over 40,000 families were screened free of charge through that program. And that included our cardiac patients, but we would mainly go for patients with cardiomyopathy or arrhythmias. So we have a fair idea now. We are writing it up at the moment. Huma has already published it in good journals, but we are also writing out the cardiac context of those genetic findings which we had through that program. And yes, a lot of them were actually had some form of genetic disorder, particularly the cardiomyopathy.
Good. So Dr. Raza Mahmood is from Georgia. What is the most common cause of cardiac issue in chest pain that you see?
In my practice, I will say psychogenic. I see a lot of especially after this COVID-19. During COVID-19, also a lot of teenagers, probably mostly girls, they were coming with chest pain, and Uncle Google has told them it's heart attack. So, and I was talking to a cardiologist who just retired from Children's Healthcare of Atlanta. I was in practice for 30 plus years. And he said he can count on his fingers like how many cardiac chest pains he has seen of those referrals. So I think in teenagers, I think we are blessed that we don't see a lot of chest pain. Most of them are non-cardiac. And cardiac, I have one HOCM, one aortic stenosis, one case of Kawasaki. So, but it's not as many cardiac, but pericarditis, I've seen that do come maybe every few months. But other arrhythmias, very uncommon. I've not seen, except long QT, I've seen few. So it's not as common. I think most of the time in teenagers, we are seeing mostly psychogenic. But it is a diagnosis of exclusion. We have to do EKG, get the echo done, and Holter monitoring. So, but most of them turn out to be psychogenic.
Thank you. And Dr. Shagufta from Oklahoma, can you share your experience?
Yeah, Assalamu alaikum. Yes, for us, pericarditis related to the COVID-19 vaccination, I have seen in few teenagers. So I did not give them their next COVID vaccine then. And other than that, Kawasaki, I had couple. And the Kawasaki ones, we did, did their full workups and they're being followed up. My question was for the cardiologists, esteemed cardiologists, what would be the follow-up for pericarditis patients, whether it is related to, any viral illness, unknown cause, or from the COVID-19 vaccine? How often they should be followed up with an EKG? If supposedly, let's say they are asymptomatic. Thank you.
Can you hear me?
Yes, ma'am.
So if it's just acute, I don't usually always follow them. Maybe I will only see them once more. If there was an effusion, you probably want to follow and make sure the effusion goes away. But if it's just pericarditis, no real troponin leak, you give them the 2-week course of ibuprofen, 1 to 2 week course of 10-day course of ibuprofen. If the symptoms get better, I don't even see them back. If I'm concerned, if there's a small effusion, I'll see them back in a few weeks, like maybe 3-4 weeks, and make sure the effusion didn't get worse. And if the symptoms are gone, effusion's gone, then I discharge them. But if it's a post-op patient, it matters, the context matters. If it's a post-op patient who had an effusion or has pericarditis, their risk of recurrence or becoming chronic is higher. So those patients we follow anyway for post-op reasons. And then if it's somebody who has a recurrence, so you treated them, they got better, and then it's back, those patients need longer follow-up, because then you'll put them on a 3-month treatment of colchicine, and then you probably want to see them. You can let the cardiologist see them, or you can see them and follow up with the EKGs, at least until the symptoms are gone. And even when the symptoms are gone, you should do good counseling, that if it comes back, if the chest pain comes back, you need to come back and see us.
Yeah, thank you. And what would be your recommendation for going for the COVID vaccine in teenagers?
We still say vaccinate, because vaccinations are protective, but there is a small percentage who have really bad, like they have myocarditis. We've seen MRI abnormalities in those patients, and in those patients, then I don't. Because we know that even if they get COVID, they don't really get that sick from COVID. So if somebody has not had any problems, they should keep getting the vaccine. But if somebody has had a problem, then we say don't get another dose. Does that make sense? Because it's hard to be someone as a provider say don't get vaccines, just because we know in more than 90% of them it's going to be safe.
Right. No, I just held it only in the teenagers who did have some pericarditis findings, but otherwise we are routinely vaccinating for everybody. But thank you, that was helpful.
You're right, absolutely. That some of them had bad myopericarditis, like with troponin leaks, and those patients I wouldn't revaccinate.
This Dr. Hemant again. I was wondering if my very good friend Dr. Masoor Sadiq is still online.
Yes, he is.
Yeah. Dr. Masoor Sadiq, Assalamu alaikum. How are you?
I'm fine. Thank you very much.
Yeah, I have the honor of doing house job with you. You and I remember doing house job long time ago, once upon a time. So
Great to see you, Raza. Great to see you.
Yeah, I mean,
You look
always
the
when
same.
I come to Lahore, I try to make sure I come and visit you. So tell me, like when I was doing house job in pediatrics in Lahore, there were so many rheumatic cases. Has it gone down the incidence of rheumatic carditis, or still is the same?
It has gone down, but it's still very much there. We are currently involved in a couple of studies. One of them is with Cincinnati Children's Hospital and one with Imperial College London, looking at the clinical profile as well as biomarkers for potential acute rheumatic fever. And yes, they are not the same as you used to see. We see more often that they come in with carditis rather than arthritis, and we have recently published that in pediatric cardiology as well. But yes, they are still very much there. If you come to my unit, 80% will be congenital heart disease, another 5% will be myocarditis, cardiomyopathies, another 5% will be rheumatic still. So it's still very much there, but not as it used to be.
Yeah, that is correct. Here in almost like 28, 30 years, I have seen only 2 cases of rheumatic chorea. And those were the
Well,
patients coming from Mexico. So, and were diagnosed with rheumatic chorea. So, but I never seen any case of rheumatic carditis here in USA. So,
yeah, you spend 2 weeks with us and you will see another 20.
Oh, yes, I know. Yeah, I've seen so much rheumatic fever, and that was like,
But they all come in with now with carditis, with heart failure, with rheumatic heart disease. We don't see arthritis anymore. If they do come in with they come in with polyarthralgia, but not with polyarthritis. I think that's because the pediatrician or the GP would treat them initially locally, and they are not admitted with arthritis anymore, but they are admitted with carditis. And rheumatic recurrence is more common than acute carditis for the first time.
but you don't admit rheumatic chorea, they go to neurologists, or you admit
Well,
them?
we treat them jointly. We don't admit them because they are not normally their cardiac findings are mild. They may have mild MR or mild to moderate at the most, so they don't need admission. But of course, they need treatment, and we jointly. Most of the times, they will come first to the neurologist, but then we often jointly sort of manage them.
Okay, very good. Thank you. Nice talking to you, Masood.
Thank you. Same here.
We have Professor Hina Sutar from Islamabad Holy Family. Would you like to share anything from your hospital? Okay, thank you. So Zainab is a student from Dow Medical. What are your impressions from this talk, Zainab? And what are your take-home messages?
Assalamu alaikum, everyone. Dr. Qasim, Jazakallah khair for such a great presentation. These topics are a little bit new for us because I'm a final year medical student. However, I think I took away quite a bit of information. I did do a clinical elective in UC Davis in pediatric cardiology. So this was a nice way to just remind myself of some of the points that I learned a couple years ago. But inshallah, I look forward to more sessions like this.
Great. Part of me wants to just go work with Dr. Masood Sadiq. I feel like I'm missing out on all the fun in Pakistan. It's
Yeah, I was amazed to see the nephrology unit. The nephrology unit the number is equal to all the patients in Children's Hospital of Michigan. So just one specialty is equal
Well,
to the whole hospital.
all the variety of things you see and the number of people you can help is it's amazing.
Okay, thank you so much, Dr. Qasim, for a wonderful, wonderful talk. I learned a lot of things myself, and the way you explained it was very nice and very involving. And thank you so much for an amazing talk. We look forward to your teaching. You have done a lot of lectures. I was looking at the list of your lectures and publications, and they're amazing. So we would very much like to benefit if you have time for us. We'll be very grateful to you.
Yes, for sure, inshallah. It's my pleasure. It's so nice to meet everyone and learn about what's happening.
Okay, thank you. If there are no other questions, then we will